Good afternoon, everyone. I hope all of you are sort of refreshed after you finish this hour's seminar or whatever. You can go to sleep, I guess, but let me not put you off to sleep straight away. Why is it that we are interested? Why is it that we are interested in measuring cardiac output? It's a very important means of what shall I say? Having a look at the cardiovascular system. So basically, apart from cardiac anesthesia, critical care, any other anesthetic kind of practice, we always look at the cardiac output being a marker of oxygen delivery to the tissues or the tissue level. And it is a way of identifying if patients are at high risk of significant mortality or morbidity or both. It is also another sort of useful guide for us to help treat or administer fluids, whether it is for resuscitation or to help us aid in giving any vasoactive drugs. So all in all, use of cardiac output monitoring is one of the important fundamentals in hemodynamic monitoring, obviously in cardiac anesthesia. So there are so many methods available to assess cardiac output or the hemodynamic status. They can be broadly classified as non-invasive, less invasive, or the invasive means. Non-invasive would obviously be ultrasound-based, echocardiography, esophageal Doppler. Less invasive, but still invasive, CVP catheters, and having an arterial catheter in the form of pulse contour analysis with various devices like flow track, combination of devices with LITCO, PICO, volume view, and obviously invasive methods would be the pulmonary artery catheter itself, which is probably one of the best. There are lots of controversies, but I would still swear by it. If you seriously look at the non-invasive part of cardiac output, one of the very basic measures of cardiac output would be your ETCO. Of course, it is another form of measuring cardiac output in various ways to quantify. But if you seriously look at the cardiac output, the carbon dioxide or end-tidal carbon dioxide trace on your monitor, that strongly reflects the cardiac output, which is why when we do CPR and stuff, we always look at the end-tidal CO2 as an indicator of cardiac output, with 20 millimeters being the cutoff to assure us of reasonably good CPR or return of spontaneous circulation. So let's go to the other ones. So what are all the various factors that influence cardiac output? The first being the ventricular preload. So we must understand that a lot of variables will affect the ventricular preload. Some augment preload, some reduce preload. So the factors which augment are obviously atrial contractility, that means more volume of blood into the ventricle. Ventricle compliance, if it is good, yes, the ventricle will hold more blood. If there is increased venous pressure, then obviously venous volume increases more pressure, and you have much more preload. And outflow resistance, that also can to a small extent influence the cardiac output in a positive manner. The preload reduces if there is inflow resistance, if there is anything stopping flow from coming in, or if the venous compartment dilates, or if you have an increased heart rate where the diastolic part is lesser to, diastolic time is lesser for filling of the ventricle. So the basis of cardiac output measurement or the use is based on the Frank-Starling mechanism, which is the initial fiber length of the myocardial muscle. The greater the fiber length or initial fiber length at the end of diastole, the stronger the force of contraction at systole. So which generally means that any change in force of contraction and thus stroke volume in response to changes in venous return. The force of contraction basically will decline once this physiological limit or threshold or yield point has reached. So this is the Frank-Starling curve or the normal curve. So the best part of it, or the best, it functions optimally at around 8 to 10 millimeters of left ventricular end-diastolic pressure to give you about the normal stroke volume of around 70 mils. These are what we call a family of from these Frank-Starling curves. And based on various changes, contractility after load, they shift to the left or to the right. So coming to the factors, enumerating them, we have to assess preload by some means. So what is an acceptable measure of preload? Generally, it is the CVP that we use, and it is acceptable to use pressure as a form of preload. So CVP or central venous pressure generally, or it is usually in terms of only the right ventricular preload. Whereas if you use the pulmonary artery diastolic pressure or occlusion pressure, it indicates the left ventricular preload. So factors which affect cardiac output, like I mentioned earlier, are contractility. So if there is an increase in contractility, what happens? It is going to eject more blood. So it shifts to the left, and therefore you have, for the same amount of LVDP, you have higher stroke volume. When there is depressed contractility or negative inotropic effects, then it shifts to the right and it falls. So it shifts to the right. So that is the effect of contractility. So contractility, preload, all of them would be part of it. So what do you use as a measure of contractility? It is the quantity of blood which has been ejected. So stroke volume becomes a part of the assessment of contractility, and the product of contractility is the stroke volume. Is essentially the end-diastolic volume minus the end-systolic volume. And if you index it to the body surface area, you have the stroke volume index. And if you index the left ventricular stroke volume, the work, then it becomes left ventricular stroke work index. Afterload, again, like I said, if the arterial blood pressure is high, or there is an aortic stenotic component, if there is a severe or high uses of high dose of vasopressor in place, then this increases the left ventricular wall stress. So by the Laplace law, we know that P is equal to PR by T. And so basically the stroke volume shifts. So this is basically the same Frank-Starling curves which you will see, and the shift occurs with increased afterload and from A to C with decreased afterload. So if the afterload decreases, the stroke volume improves, and if the afterload increases, the stroke volume decreases. But afterload per se does not alter the preload. The preload remains the same. So what about left ventricular afterload, which is going to affect the contractility or stroke volume plus cardiac output? Is basically in terms of the systemic vascular resistance. So we know that systemic vascular resistance can be obtained by this formula, mean arterial pressure minus right atrial pressure by cardiac output into 80. So the normal afterload is in terms of, we measure it in not in Woods units anymore, but in dynes per centimeter to the power of per second to the centimeter of 5. So it is about 800 to 1200 dynes. Whereas the right ventricular afterload, which again determines the left ventricular preload. So what exits from the right ventricular, enters the pulmonary blood, is the one which determines the left ventricular preload. So pulmonary vascular resistance is mean pulmonary artery pressure minus occlusion pressure, same by cardiac output into 80. And this is less than about 250 dynes. So it is normally about 4 to 5 times lesser than the right ventricular or the systemic vascular resistance. So in terms of compliance, so compliance is a very important function for determining acceptance of load by the left ventricular, right ventricle. So compliance is nothing but unit change in pressure per unit change in volume, or volume change per unit change in pressure. So the unit change in the pressure which causes a unit change in the volume is termed the compliance. So how do we have to have a measure of the left ventricular or the right ventricular function, and this is usually in terms of systolic function. So the ejection fraction is the one which we use. This is the fraction of blood that is ejected by the ventricle relative to its end-diastolic volume. So what does it mean, end-diastolic volume? So we have already determined the fraction of blood ejected is the stroke volume. So stroke volume by the endoscopic volume into 100, or in terms of percentage, is what is given as the ejection fraction. And this we use as a clinical index to evaluate the inotropic status of the myocardium or the heart. So there are various methods of calculating and measuring cardiac output. Coming to the topic proper, simplest of course, like we said, is cardiac output is equal to stroke volume into heart rate. So how do you derive stroke volume? So there are a number of arbitrary formulae. One of them is stroke volume is equal to 2 ml into pulse pressure. So cardiac output is 2 ml into pulse pressure into heart rate. That would be the simplest or the easiest way to do it on a clinical basis. But what do we use in terms of equipment? The equipment that is whatever we uses the gold standard, which is the fixed principle, which is cardiac output is equal to oxygen consumption minus the difference between the artery and the venous side. So this was basically done by Adolf Fick, and he determined, or he said that the total uptake of a substance by peripheral tissue is equal to the product of blood flow to the peripheral tissue, which is the volume or blood delivered, and the arterial venous concentration difference of the substance. So what else can you use in terms of replacement for dyes? You can use heat or thermodilution method, and the formula used is the Stewart-Hamilton equation, which is given below. So based on how fast the flowing blood can reduce the temperature introduced into the circulation. So you inject a known temperature into the right atrium and pick it up somewhere in the pulmonary artery. So the Stewart-Hamilton equation also has some presumptions. It has two corrections for specific heat and density of injectate, and for the blood and dead space volume, that is the K1 and K2, which are two constants. So all the rest, if you know, you can get the cardiac output. You know the injected volume, you know the temperature of blood, you know the temperature injected, and the difference or the delta change between the temperature as a function of time. So once you get all that, you always get a decay curve, as it's called. So the area under the curve is inversely proportional to the rate of blood flow. So this flow is equivalent to cardiac output in the absence of a shunt, which Dr. Kritika will talk to you about later. So this is a precursor for what a shunt could be and why are there shunts and how do you measure them. So the pulmonary artery catheter obviously was again the very important tool that was available to us, developed or introduced in 1970 by Swan-Ganz. And it is, of course, still considered the gold standard against which all new monitors are measured. And with new modifications, it can be a device which gives you continuous measurement, especially with the thermodilution catheter, continuous cardiac output catheters. Most of you are familiar the PA catheter and how it is placed, where it is. So generally the thermistor for measuring it is about 4 centimeters from the tip of the catheter. And if you are using only intermittent pulmonary artery, then this is the injected port opens up, or the temperature, the blood that you inject, which are known temperature injected, is in the right atrium. And if you are using a catheter which gives you continuous cardiac output, then the thermal filament is about 14 to 25 centimeters from the tip, and it is lying between the right atrium and the right ventricle and should be freely floating. It also, the way it works with the continuous cardiac output monitor is that there is a filament which gives an input signal. It uses a pseudo-random on-off energy pattern, which is occurring every 30 to 60 seconds. So every 30 to 60 seconds, it gives a pulse wave of energy, developing some temperature change, which is picked up at the tip of the catheter. And this is measured, and cross correlator matches input and output signal and produces a washout or thermodilution washout or decay curve. So if you use a dye, you use the dye concentration underneath. If there is a temperature change, you use it like this. So if it's a nice, small, nice, large peak, this is a normal cardiac output. A very slow decay is a poor cardiac output wave. And if it's a depressed or cut off, there is a leak somewhere, which is in tricuspid regurgitation. So there are some limitations also to using the thermal dilution method, which is affected by the phase of respiration, that at which point you inject, and you have to repeat it through the same point of respiratory cycle. And also the speed of the injectate can alter the measurement. So when you measure thermodilution using measure the cardiac output with PAC, generally measures the cardiac output of the right heart. Whereas if you use any measures that are, there is a transport through or across the pulmonary bed, transpulmonary thermodilution measures left heart cardiac output. So this indicator loss into the lungs. This can cause poor correlation, especially in pulmonary edema. If there is recirculation of the dye, this will also cause a prolongation of the curve, causing underestimation. So those are the invasive parts. The non-invasive parts, likely again, I said Doppler or ultrasound. So this is based on measuring the length of blood flow and the velocity in the ascending aorta during a unit time. So if you multiply this by the cross-sectional area of the aorta, then you get the cardiac output. And this multiplied by the heart rate gives you the cardiac output. So you have to know the length, the blood flow velocity across, then you have to know the cross-sectional area, and then multiply by heart rate. So the estimated the aortic cross-section can be based from normograms, or when you use the ultrasound mode itself. So cross-sectional area into velocity time integral into heart rate. So if you are using the descending aorta, as in say esophageal Doppler, then you have to use a correction factor, because a lot of, or 30% of the cardiac output goes to the upper body. So we are only measuring about 70% of cardiac output is passing through the descending aorta, for which you use a correction factor. So this is where you use a correction factor when the esophageal Doppler is in place. So the probe is in the direction, or the beam is in the direction of flow. So you know the flow time, which gives you the VTI from the area under the curve, and this into heart rate into cross-sectional area of the aorta gives you the cardiac output. So other methods, of course, again ultrasound based. So the gold standard again for cardiologists or perioperatively without the use of a PA catheter is the echocardiography, which is either transthoracic or transesophageal. Obviously, transesophageal difficult in non-intubated patients. So transthoracic, parasternal views, apical views, all of them can be used effectively to get the cross-sectional area of the aorta and the flow across the aortic valve or the pulmonary valve or the mitral valve. So all of them are inputs into the input and output across from the systemic or the ventricles. So we measure it by the Simpson's rule again. So flow is measured, like I said earlier, by the velocity time integral Doppler velocity waveform, and the cross-sectional area by planimetry. So the best TU views used for measurement is the mid-esophageal aortic long axis view or the deep transgastric long axis view with either pulse wave or a continuous wave Doppler. So the beam is best parallel to the blood flow in the deep transgastric. So these are some of the views. I don't have loops, but because I didn't put some loop. So this is almost like a parasternal view of on the other side and the deep transgastric views. So the other methods, of course, are again variations of ultrasound. The ultrasound, the ASCOM machine, the CardioQ, and basically the ultrasound beam is used to measure blood flow duration and velocity, either in the thoracic aorta using the ASCOM or the abdominal aorta using the CardioQ. But again, these are all labor intensive, then intermittent or non-continuous, and again operator dependent, which makes it a little difficult. So non-invasive monitors, the ASCOM can be, the probe can be placed. Can somebody mute?
Meeting এ আছি আমি।
Hello. Okay, right. So the ultrasonic cardiac output monitors can measure these at supracranial level. They can measure through the aorta or on the left side of the chest to measure the transpulmonary flow. The limitation being the alignment of the probe is difficult, and this may lead to errors of cross-sectional area in various physiological states. One of the important ones which have newly developed or have been there for a long time, but you have better equipment now, is the transthoracic electrical bioimpedance. So bioimpedance in short is it's an indirectly proportional to the content of thoracic fluid, whatever it is. So this could be tissue fluid, pulmonary and venous blood, aortic blood. All of these contribute to the thoracic bioimpedance. And changes in cardiac output will obviously change the amount of aortic blood that is pulsating, and this can be reflected in a change in the thoracic bioimpedance, considering that tissue volume, pulmonary and venous blood volume all are standard or stable. So generally you put a couple of the external electrodes are placed on the chest, and it measures the impedance change, which is generally the blood volume change, and the rate of change of impedance is a reflection of cardiac output. So arterial BP by total peripheral vascular resistance. So stroke volume is calculated using this formula, where VEPT is the volume of electrically participating tissue. So this is calculated, or it has been you use all these factors like height, weight, gender, so that you can come to this value. And the VET is the ventricular ejection time taken from 2 RR intervals. And the ejection phase contractility index is then used as a indirectly proportional to the thoracic bioimpedance. So these are all the various factors that are taken in for bioimpedance. So all these systems work with the same signal, but the processing part is differently. Like these companies, Biomed and Cardiodynamics, they look at the change in impedance or delta impedance change during systole, whereas the Cardiotronic or the change of the rate of impedance change during systole is taken. So either a fixed value or the rate of impedance change is used. So all of them are different measures. So just as we have a problem with the noise and external source interference when we do BIS and other thing, entropy. So modification of thoracic bioimpedance is bioreactance or thoracic bioreactance, which is the NICOM monitor. This changes or analyzes changes in the phase of electrical voltage signal when it is applied across the thorax. So basically it involves applying 2 double electrodes or dual electrodes across both sides of the chest, and changes in electrical capacitive and inductive properties are secondary to changes in intrathoracic volume, and this is what is picked up. So 75 kilohertz sine wave current is transmitted through the body, and a mean of all this will give you the final value. So we have thoracic bioimpedance, thoracic bioreactance, and then one of them can be placed on the endotracheal tube, which is the ECOM. And this uses again impedance plethysmography. So current is passed from electrode on the shaft of the ET tube, and change in impedance secondary to aortic blood flow is detected by the electrode of the cuff for the EP. So this is again artificial intelligence, AI based. So this gives you the cardiac output. So you can also do it by photoelectric plethysmography. This is again a finger based small thing like we use for pulse oximetry. Completely non-invasive, and it uses the same plethysmography of photoelectric like a volume clamp on an inflatable finger cuff. But there are very few validation studies for its efficacy. What we commonly use pulse contour analysis, first described by Erlanger and Hooker way back in 1904, who suggested that the cardiac output was proportional to arterial pulse pressure. So we use various devices, contour-related devices, to measure stroke volume and SVR as a algorithm-based determination of cardiac output and continuous cardiac output. So the devices available are the PICO, LITCO, FlowTrack for stroke volume and pulse pressure variations. PICO is basically transpulmonary thermodilution, so it gives you the left side. So you use a femoral or axillary arterial line and a central venous line combination, And this looks at SVV, PVV, that is fluid responsiveness, CO measurement, extravascular lung water, global end-diastolic volume, and cardiac index. This basically requires calibration with a thermal bolus for the static and dynamic parameters using the transpulmonary dilution. So pulse pressure variability, of course, the difference between systolic and diastolic pulse pressure throughout the cycle, and an index of 13% discriminate between responders and non-responders. So this is basically the change in the pulse pressure. Basically, you look at the difference between the change in the on the monitor. And stroke volume variation, of course, you look at the stroke volume both in systole and or diastole, and then to the respiratory cycle, and this can be used for determining volume responsiveness. 10%, more than 10% is considered to be responsive. You get the global end-diastolic index, extravascular lung water index, and the pico monitor, like the same thing like I showed you before. The transpulmonary is a later and a lower peak because it has traversed the entire pulmonary bed, whereas pulmonary artery dilution is a earlier peak. So this is the intrathoracic blood volume, which consists of right atrial end-diastolic volume, ventricular, extravascular lung, pulmonary blood volume, extravascular lung water, atrial, and left ventricular. So all of them together. So this traverses the transpulmonary bed. So we have one more called the pressure recording analytic method, or the PRAM. This again uses the area under the curve of an arterial waveform. The thing is, it does not require external calibration. Internal calibration is done by the morphology of the arterial waveform itself. And this analyzes the whole cardiac cycle area, and the area under the pressure wave is determined. This is divided into both diastolic and systolic phases with two impedances based on different characteristics. Again, accuracy is not proven. Lithium dilution, you inject a little bit of, instead of dye, you use lithium 0.5 to 2 ml, not more than 20 ml boluses. And again, there is a proprietary, these are all proprietary ones, so which can be used to give you continuous beat-to-beat cardiac output. But again, you need to calibrate it every 24 hours. So you inject some dye, and it uses the, it goes through the body and gives you, once a lithium bolus is injected, it circulates, and then you get it on the waveform. Flow track is this has become almost like a companion to most of us. This is an uncalibrated version because it's based on a lot of parameters derived from cadaveric data. And both in pediatric and adult, it has been to some extent, at least in pediatric population also. So there is a the pulsatility of the arterial waveform, they use a standard deviation over a 20-second period multiplied by the compliance. So the our software is auto-calibrated every minute, and they have so many versions now because basically arterial dysrhythmias, the dysrhythmias used to cause problem, but now they have come up with algorithms to counter that also. They have newer platforms, the Hemosphere, etc., where the calibrated pulse wave analysis is used, and you have something like play screen kind of thing. And this is again the earlier the Vigilio was only a pulse contour analysis, giving you only the arterial waveform. So this is a transpulmonary thermodilution, and it has been found comparative to the PICO system. There are various fallacies of pulse contour analysis monitors, because one is that you have to have an optimal signal. So if it is damped or under damped, then you have a problem. And dysrhythmias, like I said, or use of the mechanical circulatory assist devices like IABP or aortic regurgitation, all of them can make it inaccurate. Same thing in changes in the SVR. So there are some fallacies, but still it's a very good clinical monitor on a day-to-day basis. The other, of course, is using an indirect fix equation. You can do a NICU or the gas rebreathing. So a rebreathing apparatus is introduced into the breathing system, and this takes serial measurements every 3 minutes. So at any point the eliminated carbon dioxide at steady state, what happens is the amount of CO2 entering the lungs with the rebreathing technique via the pulmonary artery equals the cardiac output. Like I said earlier, CO2 or the entitled CO2 is a clinically useful index for cardiac output. So the same method is used. So 30 seconds of rebreathing, amount of CO2 does not change because it is equilibrated. But the amount eliminated by expiration decreases and increases in proportion to the cardiac output. So this is the basis. So once there is a calibration or a 3-minute period, if 30 seconds of rebreathing, nothing changes except the decrease and increase because of the cardiac output. And this is picked up. So the problem is it gives you only cardiac output. So there are no other additional hemodynamic values that you can derive. And obviously for rebreathing to be happening, you require to intubate the patient with fixed ventilator settings. So if the patient breathes in between, it becomes inaccurate. And other problems like trauma to the chest or shunting or low minute ventilation and high cardiac output, all of them may reduce the accuracy. But in a critically ill patient on a ventilator, this is quite a useful way instead of introducing a PA catheter, or whether contraindications for using a PA catheter. So you get a baseline, then you rebreathe, and then you stabilize. And instead of using oxygen consumption, you are using elimination of carbon dioxide. So while using partial rebreathing techniques. So to summarize, basically we have various methods, and this slide, it will be available to you on recording. So I think you can use it for comparing all these devices that are available in the market. So the pulmonary artery catheter, pulse contour analysis, LIDCO, Vigilio, Doppler, ASPOM, transpulmonary, lithium dilution. So various methods, there are some limitations to each of them. So just to summarize, this is a very important tool for hemodynamic measurement in the perioperative period, especially for cardiac anesthesiologists and critical care physicians. It has to be used complementary to other hemodynamic parameters. So it's not at the exclusion. You just can't look at cardiac output and say I'm doing good. So it could be at the expense of various other systems like high SVR or high inotrope. So you have to use it as a complementary to the other parameters that are available to us in terms of CVP or whatever preload measurement or measurement of blood pressure. So like I said, lots of tools, techniques, equipment are available for, we have described all or discussed all of them in the last 30 minutes. So please understand again, for anything biological or any method or any technique or any monitor, no single point of data is important. It is always trends. So you always have to look over it for a period of time. Any interventions you do, volume therapy, vasoactive drugs, anything. So once you do all that, the interpretation is based on you. So you are the one who determines how effective your intervention has been based on the monitoring that you have done of these hemodynamic variables. So thank you for listening patiently. I had to go through it a little faster because I was told there was only 30 minutes for this. Okay, so I think we should now, any questions before we go to the next part of the talk or next part of this today's session? Dr. Kritika is here, I think. Any questions from anyone? How often can I ask all the attendees here? How many of you are using cardiac output monitoring routinely in your practice in property? Hands can go up. Any questions? It's very important. Yes, very good. I see a couple of hands, lots of hands. That's nice. That's one. Okay. So some of them are using. So I see one, two, one of one. So that, obviously it depends on the area you're working or the institution you are working at, whether you're using cardiac output. Or obviously it is not a routine monitor. You reserve it for high risk or patients who do deserve to have cardiac output monitored. How many of you have placed PA catheters? Hands? 1, 2, 3. Only 3. They're the same who have used. Okay, that's nice. 1, 2, 3, 4, 5, 6, 6 out of 26. Not, of course, apart from Rahul and the others. So amongst the trainings, 1, 2, 3, 4, 5, 6. Right. How often have you faced trouble placing PA catheter properly? Sighting it properly? Okay. That's good. Right then. So if there are no further questions or no questions, I believe everybody knows how to measure cardiac output, what are all the equipment they are using, because see, it's very important if you are measuring. So transesophageal echo would be a very useful way of doing it. How often, how many hands up for transesophageal echo for cardiac output monitoring? 1, 2, 3, 4. Right. Okay, so same group of people who are doing it. So do I believe that the others do not have the equipment, or are they don't believe in cardiac output monitoring? Or I think Rahul should look into this, as I think part of FIACTA we should have some sort of standards of monitoring. We did start that exercise for having standards. I don't know where it is right now. Anyway, so shall we go ahead with Dr. Kritika's talk, please? Dr. Kritika,
Yes.
are you ready?
Yes, I'll just share my screen.
Please do that. Please do that. Can I request others to mute and allow her? She is from Reliance Hospital, yes? Reliance Group?
Yes, sir. Yeah.
Reliance Group, and she is just 4 months into the subspecialty of cardiac anesthesia. So good luck, Dr. Kritika. Go ahead.
Thank you, sir. Is the screen visible and am I audible?
You're quite audible and your screen is visible, at least to me.
Okay, sir. I'll just start then. Yeah.
Yes,
So good afternoon, everyone. I'm Dr. Kritika Sharma. The topic for today's presentation is intracardiac shunt calculations. So I will not be going into each and every shunt individually, but just will try to focus upon the different methods of assessing the shunts. So what do we mean by intracardiac shunts? These are basically abnormal pathways for blood flow in the heart that form either in addition to or in place of the normal pathways for blood flow. Mainly includes all the congenital heart defects that result from abnormal embryological development. So the resultant blood flow is pathological and often causes significant changes in normal physiology. So just broadly speaking, before going to intracardiac shunts, what are the different types of shunts? So we have physiological shunts and pathological shunts in our body. The physiological shunts mainly include the Thebetian veins and bronchial veins. The Thebetian veins drain the deoxygenated blood from the myocardium to the different chambers of the heart. So the deoxygenated blood gets mixed with the oxygenated blood on the left side of the heart. Similarly, the bronchial veins, they carry deoxygenated blood from the bronchial veins to the pulmonary veins, which is carrying the oxygenated blood. So this accounts for right to left shunt, both of them. Next, when we talk about the pathological shunts, we either talk about left to right or right to left shunts. The left to right shunts, the cardiac causes are ventricular septal defect, atrial septal defect, AVSDs, and the vascular pulmonary shunts, including total anomalous or partial anomalous pulmonary venous return. When we talk about right to left shunts, either it's cardiac or extracardiac in origin. In the cardiac causes includes tetralogy of Fallot, transposition of great arteries, tricuspid atresia, or Eisenmenger syndrome. In the extracardiac causes, it could be either a pulmonary cause due to ventilation to oxygen mismatch, like atelectasis, pneumonia, bronchoalveolar carcinoma, or it's a vascular pulmonary shunt, like pulmonary arteriovenous malformations. Now, the intracardiac shunts I've already described, either right to left or left to right. Right to left are mainly cyanotic shunts as it causes impairment of the oxygenation of blood by the pulmonary system. And the acyanotic shunts do not impair the blood flow and to the lungs, and the process of oxygenation is intact. It mainly includes ASD, VSD, and PDA. What are the fractions that affect your shunt fraction? Like, what are the factors that increase or decrease your right to left or left to right shunt? So it mainly includes your pulmonary vascular resistance and your systemic vascular resistance. So we should have in mind all the factors that could increase or decrease your PVR or SVR. So some important points like hypoxia, hypercarbia, acidosis, these increase your PVR, while the opposite, the high FiO2, hypocarbia, alkalosis, anemia, these will decrease your PVR. Similarly, for SVR, all the sympathetic stimulation, alpha agonists, these increase your SVR, while the vasodilators, some anesthetic agents, they decrease your SVR. Now, coming to the topic that we're going through today, that is intracardiac shunt calculations. So broadly, we can divide this topic into the non-invasive methods and the invasive methods. In the non-invasive methods, we'll be talking about 2D echo, cardiac MRI, cardiac CT, 3D printing, we'll not go into detail. Invasive methods will include oximetry run, flow ratio, indicator dye dilution technique, and angiography technique. So when do you suspect that there's a shunt? Sometimes when you see an unexplained arterial desaturation, then you can suspect a right to left shunt. It could be cardiac, it could be extracardiac in origin due to pulmonary causes. Or when there's an unexpected high oxygen content in the pulmonary artery. This could be due to a left to right shunt when the oxygenated blood is getting mixed with the deoxygenated blood on the right side of the heart. So the first method of assessment, that is echocardiography. It's one of the most widely available tools that we have. It's a key imaging modality. It is low cost. These are the advantages that makes it the first line imaging tool and a screening tool to assess the intracardiac shunts. So what all do you see in an echocardiography? You can locate the shunt, you can see a defect, so you can diagnose a congenital heart defect, which is causing the shunt. Then you can put a Doppler across that, color Doppler, and spectral Doppler, pulse wave or continuous wave. This is for the assessment of the presence, the direction of the shunt, and to see the velocity of the shunt. From the peak velocity, you can calculate the gradient across the shunt. That is, the formula is 4 times the velocity square. So you can get the peak gradient across the shunt. That will help in assessing what is the magnitude of the shunt, how severe it is, whether it needs to be operated on.
Hello. Somebody request all to mute, please.
So the peak continuous wave Doppler velocity across a shunt can be translated into a pressure gradient across the two sides of shunt lesion by applying the modified Bernoulli equation. So this is the formula, the pressure gradient by Bernoulli's equation. In case of a VSD, like shown in the picture here, the pressure gradient across the VSD, that is pressure of LV minus RV, is 4 times the peak velocity across the VSD defect. The shunt can be quantified by calculating stroke volume across the aortic and pulmonary valve to get the QP is to QS ratio. So I had already explained how to calculate the flow, that is area into VTI. So flow across the RVOT will be your QP, that is the blood flow across the pulmonary circulation. And the flow across the aortic valve, that is the blood flow in the systemic circulation, will be your QS. So in a normal patient who has no shunt, there's no defect, the flow across the RVOT is equal to the flow across the LVOT. So QP will be equal to QS. But in case of a shunt, for example, a left to right shunt, the blood flow across the pulmonary circulation will increase. So QP is to QS will be more than 1. So by getting the gradient, you get to know what is the type of shunt, and by the values, you can assess whether or not it needs to be addressed. So here, the same thing, assessment of the size of the shunt can be calculated by estimation of the ratio of the pulmonary blood flow to the systemic blood flow. that is QP and QS. Estimation of the flow can be achieved by pulsed wave Doppler velocity time integral and calculated surface area across RVOT or LVOT. So flow across the pulmonary valve QP can be calculated by pi r square or pi d square by 4, that is the area of the RVOT, multiplied by the velocity time integral across the RVOT. And similarly, the QS or systemic circulation can be systemic flow can be calculated by the VTI across LVOT multiplied by the area of the LVOT tract. So this is just an image showing the LVOT diameter and RVOT diameter. This is just transthoracic echo. And by putting a Doppler, we can get the flow and VTI can be calculated. And QP-QS ratio, we can calculate by that. Other things that we see when we do echocardiography, volume overload of the chambers. So this is in relation to the tricuspid valve. If it's a pre-tricuspid defect like in ASD, it will cause the volume overload of the right-sided heart chambers, that is the RA and RV. Similarly, if it's a post-tricuspid shunt like a ventricular septal defect, it will cause volume overload of the chambers of the left side of the heart, that is LA and LV. So all these factors, they give an idea about the type of shunt. So the magnitude of chamber enlargement will depend on the magnitude of shunt again. The size of the defect can give us a guide to the degree of shunting and guide to decide the size of the device to be used if you're going ahead with a device closure. So what is the stepwise approach when you do an echocardiography? Determine the presence of the shunt lesion, determine the volume overload on account of the shunt lesion, whether it's a pre-tricuspid or post-tri, whether it's a left-sided heart chamber enlargement or right-sided chamber enlargement. Define the size of the lesion and its location. Define the lesion for operability. How much is the shunt fraction? How much is the QP-QS ratio? So more than 1.5:1 is considered significant for a left to right shunt. And if suitable, to decide the relevant modality of treatment. So what are the limitations for the 2D echo? It's excellent for shunt localization, but the ability to quantify the shunts is still limited. To get the views, and that is the challenging part, and to get the proper alignment of the Doppler. So it's again challenging in extracardiac shunts due to the available acoustic windows. It is based on the assumption that the blood flow is laminar and has a circular cross section and fixed area size, which is not true. Also in congenital heart disease specifically, the cross-sectional area of the vessel not only is of varying shapes, but changes over the course of the cardiac cycle. And the flow is often turbulent and parabolic, especially over the RVOT. Nowadays, also, we are using 3D echo more commonly, and it is increasingly available. It is a better imaging modality. You can mark the rims of the defect better in this. There are published standards for image acquisition, post-processing, and display of 3D echo imaging in congenital heart disease, particularly useful for projection of septal walls, for evaluation of the septal defect, providing an improved appreciation of the rims of the defect and its relationship to the surrounding structures. Next, coming to contrast echo. When there are small right to left shunts which are missed upon routine echo, we can do a contrast echo or a bubble test to detect a small right to left shunt. Here we use an agitated saline or a contrast. So this is for detection of small right to left shunt. As you can see in the image, when we push agitated saline on the right side of the heart, the bubbles get eliminated by the pulmonary capillaries. But if there's a presence of bubbles on the left side of the heart, that means there's the right to left shunt. How do you differentiate between this pulmonary and intrapulmonary or intracardiac right to left shunt? So this is based on the 3-beat rule. If the appearance of the bubbles within 3 heartbeats, then it is intracardiac in origin. If it is more than 3 beats, then it is intrapulmonary. Next is cardiac MRI. So it's a cross-sectional imaging tool that allows for 2D and 3D imaging of cardiac anatomy, along with accurate and reproducible ventricular volumes and flows. So it's becoming more and more popular. It's an ideal imaging adjunct. It gives good imaging. It's one of the gold standards now amongst the non-invasive methods. And also the phase contrast cardiac MRI now can be used to calculate volumetry and the flows, and it can give you the QP-QS ratio as well. So the assessment of these shunts can be either measured directly in large vessels or be inferred from the flow quantifications across the vessels. It is accurate, the results are reproducible, the absence of radiation, all these factors makes it an ideal imaging adjunct. Now, while it can generate dimensions and rims of defects such as muscular VSD very well, it is still considered to be less accurate for thinner structures such as ASD and perimembranous VSD when compared to echo and CT. Cardiac CT, the advantage being the short scanning time. It reduces the need for the breath holding. It avoids general anesthesia, especially for unstable patients who cannot tolerate a long examination period. For them, it is preferred. And ECG gating is used to minimize the effect of cardiac motion by acquiring at a fixed point in the cardiac cycle. So these were all the non-invasive methods for assessing the intracardiac shunts. Coming to the invasive methods, we'll be talking about the 4 different methods. That is indicator dye dilution technique, which is not routinely used. We'll just briefly go through it. Angiography, again, not that common. Main 2 are oximetry run and flow ratio. So starting with the indicator dilution method, it is mainly of historical interest and rarely used outside of research studies. So it depends upon the detection and quantification of indicator substances that have been introduced into a flowing fluid. So as seen in the diagram here, the top picture is the left to right shunt. Here the indicator is injected in a vein, so which passes through the right side of the heart into the pulmonary circulation and then to the left side and into the systemic circulation, and a sample is calculated from the arterial end. So the graph is obtained. You can see the normal curve, which is colored. And in case of a left to right shunt, some amount of the indicator will be shunted, which arrives later. So because it is getting shunted from the left side of the heart, it will arrive later, which will cause a hump and prolong the disappearance of the slope. Also, the peak will be reduced because a portion of the indicator is getting shunted. Similarly, in case of a right to left shunt, again, the peak will be reduced since a part of the indicator is directly going into the systemic circulation, and that is detected first, and that arrives earlier. So the hump will come here earlier. So the main difference in the 2 graphs would be the presence of the hump, which is later in a left to right shunt and earlier in a right to left shunt. In a contrast angiography, a contrast dye is injected into a higher pressure chamber. That is, for example, the left ventricle of a suspected shunt, and used to identify VSD or PDA, but has limited ability to diagnose ASD and a poor tool for quantifying the size of the shunt. Next, coming to the oximetry run. So this is mainly done in cath procedure. So in the oximetry run, the oxygen content or the percentage saturation is measured in different chambers of the heart. So that is in the vena cava, RA, RV, pulmonary artery. At different levels, you take the samples and you check either the oxygen content or the oxygen saturation. Now, any shunt, any left to right shunt or a right to left shunt, they will cause a change in the blood oxygen saturation. So a left to right shunt is detected and localized if a significant step up in the blood oxygen saturation or content is found in the right heart chamber. So the methods are either seeing the content or the saturation. So in the oximetry run, if you are seeing the oxygen, if you're measuring the oxygen content of the blood, which includes both the oxygen bound to the hemoglobin and the dissolved oxygen in the blood. So the proposed step up that we say at atrial, ventricular, and PA level to diagnose a shunt is 2%, 1%, and 0.5% respectively, which just means that if in the vena cava you found a saturation of 85 and in the RA the saturation is stepped up to 87, that is a significant step up. So that means there is a left to right shunt. So similarly, at the ventricular level from RA to RV, if there's a 1% step up, or from RV to PA, if there's a 0.5% step up, that means there's a significant step up in oxygen content. So this is for oxygen content. For saturation, the values, the percentages are different. So the original method that was used to calculate the oxygen content was Vance-like technique, which included both the dissolved and the bound hemoglobin oxygen. But the disadvantage was it took time to obtain a reading and was technically difficult. So spectrophotometric method is technically easy and the results are quicker. So for oxygen saturation, we use spectrophotometric technique based on Beer's law, which is quick, accurate, precise, less dependent on hemoglobin, but presence of carboxyhemoglobin, elevated bilirubin, they can cause errors in the result. So how do you do oxygen saturation run? The sites. So these are the different sites from which the oxygen saturation should be measured when quantifying the intracardiac shunt. So from each location, at least a 2 ml sample should be taken, and the whole run should be within a 7-minute period. So it should be a rapid oxygen saturation run so that you are assuring that it's done in a steady state. So SVC just above the junction of the RA, IVC just below the diaphragm. In RA, you take at three different sites: low RA, mid RA, and high RA, RV, and then left and right and main pulmonary artery, then left atrial or pulmonary capillary wedge, and left ventricle or arterial sample you take. So these are the different sites from which you take the sample to calculate the saturation. And you take usually multiple samples from each site and take an average of each. So here, this is basically for oxygen saturation. Just the first column is important here, that what is the significant step up in the saturation. So for oxygen content, as I said, the significant step up was 2%, 1%, and 0.5%. Here for oxygen saturation at atrial level, more than 7%, at ventricular level from RA to RV.
I got stressed just to remember. Give me one of your caps now. I want to give it to Taylor.
So from vena cava to RA, a 7% step up in saturation. From RA to RV, a 5% step up in saturation. And from RV to P, again, a 5% step up is significant. So what are the possible causes? At atrial level, if there's a significant step up, it could be due to an ASD. If ventricular level, the most common would be VSD, PDA. At great vessel level, it could be a PDA again. So this is just an example. These are the saturation levels that is obtained at different levels. So for the vena cava SpO2, so how do we take when at the vena cava level, the saturation from SVC and IVC you take from both the places. And then this is called as Dexter formula. So 3/4 of the SVC plus 1/4 of the IVC. So here from the SVC, 67 and 68% are the two samples. So the average is 67.5. So 3/4 of 67.5 plus 1/4 of the IVC saturation, that is 73. That is 69%. So your saturation of vena cava is 69%. Your RA saturation, which is an average of 74, 84, and 79, the three samples obtained is 79. So a step up of 10%. So a more than 7% is considered to be significant. So this signifies there's a left to right shunt at the level of the RA. So it could be due to an ASD most commonly. Now, in this process, what could be the sources of error? So we should make sure that we should be sure that the samples are obtained from proper locations. Enough separate samples should be taken and an average should be obtained of the samples. Adequate quantity of blood, ideally 2 ml from each site, should be obtained. It should not be contaminated with air or blood. With the air getting dissolved, it can again change the O2 levels. You should see that there are no artifactual values. Any value which is too different from the others, you should ignore that and take an average of these similar values that are get. Samples should be obtained in a rapid enough sequence. This is to presume that the patient is in a steady state while you're doing the oximetry run, and avoid excessive negative pressure while drawing the sample. So the next method is flow ratio. That is your QPQS that we calculated on our echocardiography. This is in based on the fixed principle. So fixed principle already explained by Sir in detail. So how do we calculate the flow ratio here in cath? So QP, QS, and Q effective, these are the three things that we'll be reading, are based on the fixed principle for calculation of the cardiac output. So cardiac output based on fixed principle is oxygen consumption divided by the arteriovenous oxygen difference. So when we talk about the flow across the pulmonary capillaries, QP, that will be the oxygen consumption divided by the pulmonary venous minus the pulmonary arterial oxygen content. Similarly, for the systemic flow, it will be oxygen consumption divided by the systemic arterial minus the mixed venous oxygen content. So it will be the difference in the oxygen content on both sides of the circulation, QS and QP. So in the diagram here, you can see that there is a left to right shunt because of an ASD. So if there is no shunt, then QP should be equal to QS. But here, the QP is more than QS because of the additional blood that is going from the left to the right side of the heart. So here, if your pulmonary flow is 12 liters and your systemic flow is 4 liters, that means the QP-QS ratio here is 3, and that means 8 liters is the shunted amount of fraction QS. So for flow ratio, the numerator was oxygen consumption. How do you calculate the oxygen consumption? There were different methods using this Hood technique, the Douglas-Baggs method, polarographic method, paramagnetic method. But routinely, these are all cumbersome and we are not using any of these. So there's an empirical formula, and based on the body size and surface area, there are different charts based on gender, age, weight. And the simplest formula that we have is volume of oxygen consumption is derived by 150 times the body surface area. So this is again could lead to some discrepancy and some error in the findings, but still this is what we do routinely in our cath labs. So when we talk about the arterial oxygen content, as I told, it's hemoglobin bound oxygen and the dissolved oxygen. So in a normal, the spectrophotometric methods and all arterial oxygen content, when we take, we ignore the dissolved oxygen part, that is 0.003 into PO2, which is usually a very small fraction and it is insignificant. But when it becomes significant is in patients who are receiving high FiO2. That is why while doing these studies, these should be performed on room air ideally. So flow ratio, again, the same thing. QS, systemic flow, is oxygen consumption divided by the hemoglobin bound oxygen, difference in the arterial and venous. So HB into 1.34, which is the Huffner's constant, and you multiply it by 10 so that you derive the flow in liters per minute, and into the difference in the saturation of arterial and mixed venous. Similarly, QP is the same. In denominator, it's the pulmonary venous and pulmonary arterial oxygen content. And getting the ratio, when we take the ratio, you ignore the oxygen consumption, and it's just FiO2 minus MvO2 divided by PvO2 minus PaO2. So location of shunt as determined by the site of oxygen step up. As I said, if it's in if the step up is in pulmonary artery, the example is PDA. Step up in RV could be due to a VSD. Step up in RA could be due to an ASD. And what is the site of collecting mixed venous sample when you calculate at each level? So in case of when the step up is in pulmonary artery, you can take the mixed venous sample from the RV, like upstream of that. And you can take an average of the samples obtained during the oximetry run. If the step up is in right ventricle, then you take the mixed venous sample before that, that is in the RA. Again, an average of the samples during the oximetry run. And if the step up site is in the right atrium, then the mixed venous sample will be before that, that is the vena cava oxygen content. So 3/4 SVC plus 1/4 of the IVC oxygen content. So flow ratio, QS, QP, the total blood flow that flows through systemic and pulmonary capillaries respectively. What is Q effective? It is the effective flow. That is, it constitutes only the desaturated systemic venous blood that flows through the lungs and is actually oxygenated in the lungs. So this ignores the shunted fraction. So the blood that the deoxygenated blood that we are receiving from the veins that is actually going to the lungs and getting oxygenated is the Q effective. So in the absence of any shunt, the pulmonary flow is equal to systemic flow is equal to the effective flow. So just seeing in the diagram here, Q effective is from the systemic vein to pulmonary artery. The flow is Q effective. From here will be the QP, that is the pulmonary flow going into the pulmonary vein. Then again Q effective to systemic artery, and QS is systemic artery to systemic vein. In case of a left to right shunt, here additional shunted blood is coming from the pulmonary vein to pulmonary artery side, like from the basically left side to the right side. So the pulmonary flow will be equal to the effective flow plus the left to right shunted flow. Similarly, the systemic flow is equal to effective flow plus the right to left shunted flow. So left to right shunt can be calculated as QP minus Q effective, and right to left shunt QS minus Q effective. So in case of a bidirectional shunt, you can use the effective flow formula, and it could be the difference in the, so you can use this to calculate the difference in the left to right and right to left shunt. This is just an example to calculate a 6-month-old male that given the values in a VSD, VO2 is 75 ml per minute, SVC, IVC saturation is given, pulmonary artery 87%, aortic saturation, that is systemic arterial, is 99, pulmonary vein 99, and HB is 11 gram per deciliter. So if you put the same formulas, that is QS is equal to VO2, that is 75, divided by HB 11 into 1.34 into the saturation difference, that is for QS systemic artery minus mixed venous. So systemic artery here will be aortic, that is 0.99, minus the venous, that is 0.7. So that will give you QS is 1.7. Similarly, QP, denominator, you will put pulmonary artery minus venous. So that will give you 4.2 liters per minute. So here 1.7 was your, this is another example, left to right shunt. Here 1.7 liters per minute is coming from the systemic QS. QP is here 4.2 liters per minute. So the rest of it, that is again 4.2 is coming in the pulmonary veins and 1.7 is to the systemic. So the remainder is the shunted blood from the left to right side of the heart. So the QP/QS ratio here will be 4.2 divided by 1.7, which is 2.5:1, which is a significant amount. So 1.5 to 2 is moderate, and more than 2 is considered a significant shunt fraction. The same thing here explained. So total left to right shunt will be the difference in 4.2 and 1.7, which is 2.5 liters. So 2.5 liters is the shunted fraction that is going across the VST. Thank you.
Thank you, Dr. Kritika, for maintaining time, and thank you for elaborating so well on how to measure intracardiac shunt, what are the shunts, what are all the various methods that you use to measure or quantify shunts, especially the current way of, So one must remember that shunts, intracardiac shunts are usually a pediatric age problem. And though when we were training, it was all oximetry runs, and the problem with that was you had an anesthetized child, and basically a small kid or a small few kilos baby or maybe a couple of kilos. By the time you took out all those samples, the patient was, basically hypotensive, plus whatever they lost for cannulation. So we always sometimes had to transfuse blood to these kids. The other issue, of course, is if you are anesthetizing a child, whether it is MAC or intubation, you must always remember that whenever they are doing an oximetry run, you should come back to room air FiO2 0.21. So you should stop supplementing about oxygen if you are doing an oximetry run about 15 minutes prior to the sampling part. So oximetry is basically sometimes done, yes, but like she mentioned, for carbon monoxide or any other forms of carboxyhemoglobin and all of them could be a problem. So co-oximetry is a very common sort of apparatus available in the cath labs. So if you are doing a oximetry run, you should always have a co-oximeter to pick up the other forms of hemoglobin also. So that is one. So in terms of oximetry run, and remember intracardiac shunts, like she has mentioned, usually children. So MRI becomes a very useful adjunct to get all these shunts done or shunts quantified. And sometimes post-surgery also, when repairs are done or rerouting is done, these children also require to have intracardiac shunts calculated, because we do accept some shunt across some in times when there is severe PAH. So you do leave a leak in terms of post repair, so that they would have some amount of shunt which is persistent. So these two would be picked up by MR. So CT, yes, quicker times are be easily done, but the amount of exposure radiation wise could also be reduced. So there are multiple ways available, but the oximetry now seems to be the least of the ways of assessing intracardiac shunts. Always remember that we have only dealt with intracardiac shunts, which are generally structural defects in the neurological defects. But quite often in perioperative practice, there are other extrapulmonary shunts also causing shunting across the systemic and pulmonary bed. So the effective or the Q effective would be a good way of picking up all that. And so one has to be familiar with all the ways of measuring shunts and remembering the indications or the causes for these shunts happening in the first place. So are there any questions from any of the attendees, please? Any questions? Any comments? I don't hear anything. I think basically this topic was advertised or rather put up on the WhatsApp groups quite early. So I'm sure most of you would have read up a little bit for these sessions. So I would suggest, in case you're not doing it, please read up and come so that it becomes interactive and there is some amount of discussion or clearing doubts, at least if there is no discussion. So I think that should be that should happen quite often because that's the only way you learn. And if at all you are during your regular teaching sessions at your institute, please do if you have the doubts which you come up or think about later, have them cleared by your senior colleagues. So these are all fundamentals in practice of cardiac anesthesia which you should be thorough about.